This episode is sponsored by Dr. Chrono by EverHealth, the #1 mobile all-in-one EHR. Built specifically for medical practices, Dr. Chrono includes an integrated feature that powers a seamless payments acceptance experience. Dr. Chrono Payments offers multiple ways for patients to pay as well as insurance credit card processing. As a Dr. Chrono customer, you can easily activate our fully integrated payment solution that will streamline your cash flow and help you get paid anytime from anywhere. Deliver the best patient experience with a fast and easy way to collect payments. Visit drchrono.com/payments. That's drchrono.com/payments to learn more about Dr. Chrono today. Direct primary care is an innovative, alternative path to insurance-driven healthcare. Typically, a patient pays their doctor a low monthly membership and, in return, builds a lasting relationship with their doctor and has their doctor available at their fingertips. Welcome to the My DPC Story podcast, where each week you will hear the ever-so-relatable stories shared by physicians who have chosen to practice medicine in their individual communities through the direct primary care model. I'm your host, Marielle Concepcion, family physician, DPC owner, and former fee-for-service doctor. I hope you enjoy today's episode and come away feeling inspired about the future of patient care, direct primary care.
So in the early 2000s, I got tired of starting every office visit with, "Sorry, I'm running late," and then never having enough time to adequately deal with my patients. And it didn't make sense to me that someone else would deal with them after hours. I figured if it's important enough to talk to someone after hours, they ought to be talking to me. So I decided to do something different. And in 2005, I opened up Encinitas Personal Health Care. I am Dr. Marty Schulman, located in Encinitas, California, and this is my DPC story.
Dr. Marty Schulman graduated from UC Berkeley in 1981 and the UC San Diego School of Medicine in 1985. He completed his hometown's Long Beach Memorial Family Medicine residency program in 1988. He worked as an associate in a small family medicine practice in Encinitas, California, before being hired in 1990 to fill a clinical faculty position at UC San Diego. In addition to teaching students and residents, he became the medical director of his clinic site and later served as the clinical service chief for the Division of Family Medicine. He was one of 2 family medicine faculty members chosen for the inaugural class of UC San Diego's Academy of Clinician Scholars. In 2005, Dr. Schulman opened Encinitas Personal Healthcare, Inc. after deciding that he wanted to provide concierge-style medical care at a reasonable cost to patients. To do so, he created a practice model combining low annual fees with low overhead. Opting out of Medicare and having no insurance contracts allowed for him to be paid a reasonable, non-discounted fee in full at the time of service. For 13 years, Dr. Schulman incorporated travel medicine into his solo practice. For the last 12 years, he has served as the medical consultant for a 6-bed residential treatment center for eating disorder patients. He has also maintained his relationship with UC San Diego through his hospital medical staff affiliation and work as part of the physician assessment teams at the PACE program and the Physician Retraining and Reentry program. Welcome to the podcast, Dr. Schulman.
Great to be here.
This is such an awesome opportunity for the listeners as well as myself, just because you and I were sharing the stage at the American Academy of Family Practice co-sponsored DPC Summit in Kansas City. And there, people got a little bit of a taste of your story, but it was very truncated. And so this gives you a different floor on which to share your story and to be able to share a longer version of your story. So I wanted to get started with the fact that you, like you said in your opening statement, you've been open in your DPC for a lot longer than most of us in this community. And so you graduated UCSD School of Medicine in 1985, and you've practiced during the time when the insurance landscape was very different. And so I want to ask, when you graduated medical school, did you ever want to practice independently, or were you employed after you graduated residency up until you decided to open your DPC?
Well, early on, I had no thought of doing solo practice. Out of residency in Long Beach, California, I joined a practice with 3 other family medicine docs in Encinitas. I had met my wife during medical school. We went up to Long Beach for residency, but we knew we wanted to come back here to the San Diego area. And it was a great practice. And I really enjoyed working with the other 3 docs and all the patients. But at the end of the year, it was, we like you and you like us. And so now it's time to buy into the practice. And that was the heyday of HMO managed care, capitated managed care. And I just didn't feel real confident doing that at that point. And so they allowed me to stay on until I found somewhere else to work. And that somewhere else very quickly turned out to be clinical faculty practice at UCSD, where I'd gone to medical school. And so I started there, and that was in February of 1990. And did mostly clinical work, did some medical student teaching, did a lot of resident teaching, attending in the clinic and all that. And then pretty quickly, I became the medical director of my site. And at one point, I was the clinical service chief for 3 years. But then after about 10, 12 years, that's when I started thinking about doing something else. And the thought of going solo probably should have been scarier than the thought of buying into an established practice, but just had to go for it at that time.
I hear you. And I want to ask, because you were involved with training others, training the future of family medicine in your case, did you see the residents who were in training and as they graduated have the same outlook in terms of, I'm going from here residency to an employed physician, or did you see some of those physicians branch out on their own?
No, everybody seemed to be joining something established. Very few people were going into solo practice. I should mention one of my residency colleagues went into solo practice very near where you live in practice. And I just couldn't believe it. And that's been his whole life, is in the same place. And I envy that. So, but no, I haven't seen people with the goal of, I want to go out on my own from the get-go.
Thank you for sharing that. And when you mentioned how you probably should have been more scared thinking about opening a solo practice rather than joining a practice or becoming a partner in a practice, how did you then bridge the gap between physician knowledge and business owner knowledge when the landscape in DPC was even very different because there were very few resources? And I mean, you've been open for 17 years, going on 18 years. The resources are very recent, I feel, in terms of all of the Facebook groups and the resources that people have frequently mentioned on this podcast.
Yeah, we certainly were not trained in business in any way during medical school or residency. So here are the resources I had as I was trying to figure out what to do. And part of it has to do with how I came up with my model. The way of being able to provide the type of care that I wanted to provide, on-time visits that last 30 to 60 minutes, sometimes quite a bit longer, being available to people 24/7 essentially, is to have fewer patients, right? How do you do that? You either have to charge more or have a lower overhead so that you can have a margin to pay yourself and live comfortably. So on the low overhead side, there was this physician, Gordon Moore, who was sort of the pioneer of I'm going to practice all by myself, and I'm going to have one room, and I'm going to take vital signs. I'm going to do everything like that. And I don't recall that he was cash only, though. I think he probably dealt with insurance back then. So, but I'm going to deal with everything myself and not have to pay anybody and keep my overhead low. And then I don't have to see as many people. And he eventually hired one assistant, I believe, and went from there. So that's one side of it. And then the other was, that was the fairly early days of concierge medicine. And the first guy to do concierge medicine, if I remember correctly, was one of the team physicians for the Seattle Supersonics, who $10,000 a year, and he'll see you whenever you want to be seen. If you want him to go to the cardiologist with you, he'll do that. So think of how few patients you need at $10,000 a year. Yeah, that can be done, but that's sort of a crazy amount. So I wanted something in between. So the resource on concierge medicine back then was, first it went through a couple of different names. There was the American Academy or whatever it was of concierge medicine. And that at one point morphed into the Society for Innovative Medical Practice Design, or SIMPD for short. And actually, I attended a conference that they had. It was a weekend conference in Dallas and learned quite a bit. And there was lawyers there and physicians who were already practicing and such. So learned the resources. And so I found a lawyer to help me with becoming incorporated and help me with a patient consent form such that it was actually a contract to be part of my practice. And I call it a membership contract because I consider my patients to be members in the practice. Mm-hmm. So I got that help. I used a real estate person to find space. Lesson learned, don't use the real estate person who's also the listing agent. Don't do that, because whose side is that person on? And did things work? Could things have been better? Probably. I don't know. But that's one lesson. Have your own person, just like when you're dealing with a home sale. So anyway, those were the resources that I had and took it from there.
Stay with us. We'll be right back. Thank you to Spruce Health for supporting the My DPC Story podcast. The ways we communicate have changed dramatically over the past decades, but technology and tools in healthcare have not kept pace. Patients want more access and digital convenience, as well as the ability to text their care teams. Care teams are inundated with more communication and rising expectations, but are still using tools and technology stuck in prior decades. Spruce Health created a solution for the tech-forward DPC practice by creating a communication product designed to serve both the patient and the doctor through intuitive HIPAA-compliant workflows, tagging, scheduled messages, and triage templates ready for use, whether you're on your phone or in the exam room. New users get 20% off for the first 12 months of a paid plan with code MARYAL20. That's MARYAL20. So check out Spruce Health today at sprucehealth.com or check out the link in the show notes. Awesome. And on that note, as you're talking about your space, do you own your building or do you rent your building?
I wish I owned my building. No, my initial practice was in a dedicated building, mostly with medical practices in it, not exclusively. Lesson number 2, as far as space goes, besides having the right representative, is don't get too much. I got 1,000 square feet, 2 exam rooms. Why did I need 2 exam rooms if I'm piggybacking one patient an hour after an hour after an hour? Why do I need a room to have a second person in? And the plan had been to sublease that space, and I did not do enough of that. And basically, at the end of that 7-year lease, in which I put way too much into tenant improvements, it's like, bye. And I was fortunate to have a colleague who's a chiropractor who had space in where I practice now. There's 4 rooms, and in the 4 rooms, we have 2 chiropractors, 2 massage therapists, 1 acupuncturist, and I have my own room that's 13.5 by 12 square feet, and I do everything in here. I have a view of I call it the non-waiting room, and so I can see when my patients come in, don't have any staff. It's just go get them, and we do our thing at that point.
Awesome. And for the listeners, can you please share what's your view like from your office?
As we speak, the door to my office is glass, and then I'm looking out the front door, which is also glass. There's a parking lot, 1 road, railroad tracks, another road, and then the beach, the ocean, I should say. So I'm right across the street from San Elijo State Beach in Cardiff by the Sea, California. There's a few palm trees that get in the way of my view. Oh.
Very different than Arnold. Oh my goodness.
Oh yeah.
Amazing. So now I love that you've shared how you developed your model and your space. So I want to ask, when you were opening, and you had practiced in the area. Did patients from your previous practice come join you, or how did the early days go with regards to onboarding patients to your practice?
Yeah, not as much as I had hoped. More patients than I thought would come than actually came. So that part was a little disappointing. So I had to grow from without rather than from within in terms of just expecting a whole bunch of folks to come see me. Now, that being said, some of them took a while and eventually found me. Some came with me and went away, and then they've come back. I mean, it's variable. So I still have a fair number of patients from when I left my faculty practice, but otherwise it's just grown on its own.
And because, this model was very new in terms of it wasn't concierge, it wasn't a typical insurance-based clinic. How did you explain your practice to people who were interested? And has that explanation or description changed over time?
Well, I mean, you can still call it concierge. I don't like that term, though, because it implies an elitism. So I call it concierge light. For a while, the term was boutique. It was a boutique medical practice. That's sort of gone by the wayside, I think. So I describe it as having concierge style benefits, basically appointments same day or the next day. They typically start on time. We're not rushed. I block out at least half an hour. I usually block out an hour. If we finish early, that's great. I'm available 24/7 to my patients. Now, it's one thing to do that if you have 2,000 patients or 3,000 patients. It's quite another to do it with the volume that I have, which is, quite frankly, only around 200 patients. I've been able to not require a fuller load than that because I've had some other things that have helped supplement my income. So I'm not completely reliant on just seeing patients and having a certain number of patient memberships to get by. But it just makes sense to me that, again, after hours, if someone needs you, why should they talk to a doctor or a corporate nurse or something like that who doesn't know them? And can I give one story of where that made all the difference in the world?
Oh, please.
So at that time, he was in his early 70s, but he looked like he was early 50s. This gentleman who went to the club every day, played golf in the afternoon, very gregarious. And I got a call at 11:30 at night from his daughter from the hospital or a hospital in Hong Kong. And he had had a stroke. It turns out that he had a vertebral artery dissection that was thrombotic. And he lost vision. I think his speech was affected. He lost coordination, and it was approaching the magic 3-hour mark. And the neurologist there in the emergency department or wherever they were offered TPA, but recommended against it because of the bleeding risk. And basically, knowing the patient, I knew that if this patient woke up the next morning in that condition and knowing he's going to be in that condition the rest of his life, he's not going to like that. So it was worth every risk. And so I told the neurologist, and my patient still quotes me to this day, I know my patient, give him the TPA. And he did. And within hours, his vision came back. His pretty much everything resolved. He's got a little visual field defect, and that's it. And he's the happiest guy in the world. He lived long enough to get and survive tongue cancer, and he's still going strong. If that call goes to anybody else, what are they going to say? They're just going to defer to the doctor there.
That's incredible. And that really hits home for me. I remember when my dad had a stroke in the Philippines and I flew over there and I needed to get in touch with his fee-for-service doctor. It was very challenging to try to get in touch with him, as well as to get photocopy pictures that I had taken on my phone of his medical records from the Philippines over there. So just thinking about your patient and your patient's daughter and the ability to just call you whenever. It's a beautiful way to be able to practice medicine for those people. Some are not comfortable with the 24/7 call, but for that family, that just really hits home for me. And I think that is incredible that was their experience, because it really changed that family's course. So.
Absolutely. And let me go a little further on that. People are going to say 24/7, you're on call all the time, aren't you? How do you sleep? So I've been doing this. I'm in my 17th year. I've been awakened maybe 10 times by a phone call in the middle of the night. And I once had to scold, it sounds ageist again, because the other patient was ordered. I think she was 80-ish. And she had woken up at 1 a.m. with her very first episode of renal colic. And her husband calls me in the morning to describe what the symptoms are. And I said, oh, sounds like she's having a kidney stone. She should go to the emergency department. Why didn't you call me when it started? Because I would have given you the exact same information and gone right back to sleep. And they said, well, we didn't want to wake you. So I scolded her for not calling me at 1 a.m. So no, that's not a burden. When I'm on vacation, still, as long as I got Wi-Fi or coverage somehow or other, I'm available. And before I go, my patients get an MSA email. MSA is a Marty service announcement as opposed to a PSA public service announcement. Some people call it a Marty-gram, but they know where I'm going to be. They know the time zone difference. They know when I'm on an airplane. And if I'm going to be unavailable for more than an hour or two at a time, then I have a physician in the community who's available by phone if need be. But otherwise, I got the coverage. And the proviso with that is typically at the bottom of the A, it always says, and if you're really having a problem for which you can't wait to speak to me, or so, you probably should be going to the emergency room anyway. One more thing about vacation, because of that MSA and the patients respect my time and all that, that I hardly ever get bugged while I'm away for a week to 10 days because they know it's my downtime and they're very respectful of that. When they contact me and I'm on vacation, it's because they really need something urgent, and I'm all too happy to take care of that because it needs to be taken care of.
Absolutely. And when you mention vacation, and if, there is a circumstance where you have to have a local physician cover you, in terms of your guys' agreement, do you pay that person per hour that they're actually taking the calls from the patient? How do you integrate them into your EMR? How does that work if you have to have someone cover you?
Well, I do the same for him. And so it's just, hey, can you put down these dates? Yeah, I'll be available, and vice versa. So there's no reimbursement or anything. I can't remember the last time either of us needed to see one of the other's patients anyway. If I had to see one of his patients, I would just do a note in my own EMR and copy it to my friend, and he would do the same for me. Simple as that.
Thank you for sharing that, though, because I'm sure there's other listeners who are wanting to do the micro practice model and are thinking of those legal questions. How do I cover? How do I pay them? But I love that what you've shared is a way to do it without the red tape of administration, and that your patients and that you're able to even communicate with your friends, like, this is what's going on with my patient at this time. If they call about this, I want to prep you for XYZ issue. So that's awesome. So now I want to get into the nitty-gritty of your practice and the model. And I want to start with pricing, because your pricing is different in terms of it's not, this is how much per member per month based on age. So can you please share what your pricing model is, how your pricing is set up, and has your pricing changed over time?
It hasn't changed a whole lot, except I've increased things just a little bit over time, but the basic model has been the same since 2005. Back then, the thought of just doing a monthly payment, the fear was, unless you charged in arrears, if you charge it in advance, the fear was looking like a capitated medical plan. And here in California, it's the Knox-Keene plan that we were worried about looking like. We're nothing like that whatsoever, but it wasn't so obvious to people. So that's one of the reasons I did it the way I did. So it consists of two things. It consists of a practice membership fee and a per visit fee. And part of the justification for that is I call it the Congress plan. The practice membership fee is shared equally amongst all my patients, right? Everybody pays the same. And how does the Senate work? Every state, whether you're California or Rhode Island, gets 2 senators. So we're all the same there. The House of Representatives, it's apportioned according to the size. So California has the most number of representatives, and there are some states that have 1. And so why should I try and come up with an amount of just a standard fee that, well, do I need to lean towards minimal users or to the heavy users? This way, everybody pays the same for the membership fee, and the heavy users who need to see me 8 times a year, they're going to pay more per year. And those who just want to have me available just in case and might not see me at all, why should they sort of be supplementing others? So that's the Congress plan, the same in one way and proportional the other way. So my fees now are, first family member is $800 per year. Each additional family member is $500. And I don't charge it for the first 3 months, so I let people try it out. And then after that, most people choose to pay quarterly, so I just send them a quarterly invoice. I have a few people just want to pay once a year, and that's fine. My practice, the office visit fee, it used to be based on $200 an hour, and last year or the year before that, I think I bumped it up to $250. So generally $250 for an hour, $125 for half an hour. The very rare quicker visit, I'll do half again at $62.50. I should probably round that one way or the other. But also different, what I do differently, I am cash only. So my patients are directly contracted with me. Almost everybody is part of a PPO plan, so they can submit for service. But what do you need for that? You need details of the visit. So I send them a receipt anyway. So the receipt, besides listing my name and the practice info and my tax ID number, it lists the T code for the visit and an ICD-9 code or codes for the diagnoses. And so it'll typically say 99214 level 4 office visit for the following. And I do have the codes for preventive care visits as well. But basically, once that's done, a patient can attach that one page to a claim form and send it to their insurance companies.
You mentioned how most of your patients have a PPO. What are the income demographics of your patients? And in terms of adults versus kids, who's in your practice right now?
Age-wise, I from the beginning, I started with 7 and over. I did not want to deal with childhood vaccinations. And in fact, part of my practice originally, one of the ways I supplemented early on was by doing travel medicine, because I had done that at UCSD. And so I had a full stock of things, but even so, ages 7 and up, so as to not have to deal with MMR and some of the other ones from childhood. But slowly but surely, pharmacies are so available with the vaccinations, and accessibility to small practices like mine for yellow fever vaccine went away several years ago. And I just said, screw it, and gave up doing any vaccinations whatsoever. I gave up the travel medicine practice component. And by the way, that was available to anyone. That was not restricted to member patients. So as far as income goes, I have a number of uber wealthy patients, but I have the vast majority are nowhere near that. It's worth it to them to pay extra out of pocket to be able to have the accessibility and the care that they get from me.
And thank you for sharing that, because like you said, when you were starting out, the $10,000 per person per year was not in alignment with what you wanted to bring to your community. So I love that. And I love that you have this varied population. So can you talk about your additional fees? So fees for certain procedures, and how are those charged for members versus somebody who's coming for a one-off visit?
Well, I typically don't do one-off visits. It's not fair to the members for the most part. Although the exception to that is, and this is a part of the member services, is if Aunt Jenny is visiting from out of town and something comes up and she needs to be seen, I'll be happy to see Aunt Jenny, and there's no membership fee, and it'll just be the regular fee for service visits. As far as procedure fees go, it's pretty much included. I generally, even for the most part, included EKGs. Once in a while, I might charge separately for an EKG, but it was sort of like, well, if it's an hour-long visit, okay, the EKG's included. If it's a half-an-hour visit, but I had to do the EKG, okay, I'll throw that in. And I think my fee for that was $35, and I finally increased it all the way to $50. So, but I'm trying to remember if I've stopped doing lumps and bumps, skin biopsy stuff. There's too many dermatologists around, and they're going to do a way better job than me anyway. So I may have charged for those early on, but that's it.
Yeah. Gotcha. And when you talk about your services, when you talk about your practice size, and you have mentioned that ideally you have 30, 60 minutes for between patients. How have you been able to manage this without staff?
Pretty easy, because, I know how to take vital signs. I had to learn how to give shots. I actually went through all of medical school and all of residency without ever once giving a shot.
Wow.
The very first intramuscular injection I ever gave was in the private practice that I joined out of residency. And they had a Saturday morning session. A lot of it was urgent care type of stuff. But as the new guy, I had the most frequent ones. And there was a woman who had to get her every 4 weeks stelazine injection. And the nurse couldn't do it. I had to do it. So that was my first one. And then, by the way, I did start out with a medical assistant. I forgot that part. I had a medical assistant / receptionist the first 2 years. Problem was after 2 years, I was paying her more than I was paying myself. And it was time for her to go. So that's when I went uber solo, because I wasn't completely to begin with. But no, I can make appointments. I'd actually rather be in charge of my schedule than anyone else anyway, because I can figure out how much time and where's best and all that. So being solo is just fine. I need to add on to that, though. The hardest part of being solo, though, was actually keeping the books. And so I think it's been 7 years now, maybe 8. I finally gave in, and I have a friend who's a bookkeeper, and she took over. And that she's worth every penny that I pay her to do that, because especially if you're incorporated and there's so much more involved. Maybe not so much more. There's more involved if you're incorporated than if you're not. But regardless, you have a whole lot of things to keep track of. And just to be able to give it to her, I give her documents every other week. She makes sure everything checks out, and we're ready to go for tax season.
And I want to ask a few more details there, because when you were doing it before that 7 to 8 year mark hit and you hired the bookkeeper, what were some of your biggest pain points in terms of, it sounds like catching up on stuff was a big one, but how did you try to manage it all before you hired your bookkeeper?
How I ended up managing it most years was, as tax season approached, it's like almost going away for the weekend and locking myself in a hotel just to get it done. There's checking accounts that need to be checked against the QuickBooks, and credit card things that need to go into QuickBooks and all that. That was a pain in the behind. So I was happy to give that up.
Well, I appreciate that honesty, because again, you and myself and everyone who is a physician who chooses DPC, we go into this, most of us without some kind of business degree or business training. And there's chatter about, what do you use? Xero, QuickBooks, a bookkeeper, and everybody does it differently. But I will say that definitely is something that I hope a lot of people will just take those words, and especially about the finances, and think about how they're planning their own finances, or how their finances are working well, or if they could be improved just by hearing your story. In terms of scheduling, you mentioned how you like having the control over your schedule. And I completely agree with that. I love being able to pivot and to be able to fit people in, especially being a relationship-based doctor. We know our patients, and we know which ones will take a little bit longer, or which ones have social issues going on where we might need to do a family visit. So for you, do you allow your patients to self-schedule?
Absolutely not. And I thought about that, but no, that's something I don't want to give up control on. But scheduling is as easy as sending me a text message too. And so sometimes we don't talk. It's just message, hey, we're due for a visit here, and it can be an acute or a follow-up. And either way, it can be a text message. Sometimes it's email, sometimes they call. But no, I want to have that control. And early on, I was always, if someone was scheduling an appointment, it went right into my EMR. But I also kept my Google Calendar, right? So just put it in Google, because Google's with me everywhere, right? The Google Calendar. And so I'm making appointments on my cell phone. And then, all right, when they show up and it's time for their appointment, okay, then I put it in the EMR. There's no reason it needs to be in the EMR in advance. So that was something took me a surprisingly long time to figure out. And years and years in, there's still things I can change and do better.
Yeah.
Or easier.
Mm-hmm. And you have the freedom to do that. So that's incredible.
That's right. I just have to speak to the boss and tell him the better way to do it. And he usually listens.
By chance, are you a Gemini?
No.
Oh,
Yeah.
I joke about that a lot because I am a Gemini, and so I just want to ask, but I digress.
Do you have your twin? Is that the idea?
The twin who's the squirrely twin who likes the shiny new object, and then the twin who's like, remember the consequences if you choose to chase after that squirrely shiny object. Yeah.
Yeah.
So when you talked about how you wanted to have the waiting room that has no waiting, and you've designed your schedule so that your patients are getting 30, 60-minute visits, how many patients do you see typically in a day in person versus how many do you take care of versus over telemedicine?
Actually, during the peak of the COVID stay-at-home stuff, the lockdown, the majority were televisits, but now I do those very rarely. And I still do an occasional house call. So most are in person. My visits per day are anywhere from 0 to usually there's 1 or 2. Again, remember, I'm running with 200 patients. And what I learned way back at the beginning was that on average, around 1% of your patients need to see you every day. So think about that. If you have 200 patients, that's 2. If you have 2,000 patients, that's why you're seeing 20 to 25 patients a day. And that's untenable. So anyway, there's always more to do. And part of for me, the timing was the 2 outside activities that to a certain extent sustained my practice while I was trying to do above and beyond what I was just doing. So those 2 things are, one, being the medical consultant for a residential treatment center for women with eating disorders. And I actually got into that when one of my patients who owned a facility said, hey, our medical consultant is leaving. Would you like to do that? And it's as many as 6 people at a time. And for those who don't know, a residential treatment center it's 1 level shy of being in hospital. So there's orders that are written, and now we have an EMR for that, of course, and followed by nursing staff and an admission history and physical. And then instead of daily progress notes, it's weekly visits. And so I worked with that one until it closed. And then another one that's actually part of a very large corporation opened up. And the psychiatrist who got hired for that one knew me from the previous one and recommended me. And I've been doing that since it opened about 8 years ago, something like that. And so I have to have time in my schedule to do that. But the cool thing about not scheduling way out is the flexibility of, okay, I have a new patient coming in, I got to go do the admission H&P, and here's a block of time I can do it because I haven't scheduled anyone there, or anticipating that it's going to be there, knowing not to put someone in there. So that's one thing. The other thing was, for a number of years, when I left UCSD full-time, left the clinical practice, I started working with UCSD's PACE program, Physician Assessment and Clinical Education, essentially an evaluation, a competency evaluation program, as well as remediation education. And I worked strictly on the evaluation side of things. And that ended up being a 50% position for me. One of the beautiful things about that was I never had to worry about getting healthcare independently because I maintained it through UCSD, even working part-time. And the other beautiful thing about that was I was already contributing to the pension, and that continued. And so a couple of years ago, I decided, well, I'd like to stop working 150% time and just work 100% time. So I retired from there and substituted the salary from there with the pension. And again, that supplements that. The eating disorder center actually flows through my clinical practice, through my corporation, but that supplements my income from the clinical practice as well.
And as you mentioned, how you have your practice, your Encinitas personal healthcare practice, but you also have these activities that have supplemented. What advice would you give to other people, especially those who are opening their DPC or looking to start supplementing? How would you advise them to think about supplementing their income in terms of what types of jobs mesh well with DPC in terms of having the time to be able to do your DPC plus something else? Yeah, I would love to hear your thoughts on that.
Yeah, there's probably other opportunities out there. I mean, there's centers out there that are residential treatment centers that need docs. Can you do urgent care shifts? That gets a little dicey if you're giving up all your insurance contracts and opting out of Medicare. And then what happens when you go work for someone else? I don't know, quite frankly, how that works. But the beauty of minimal number of patients and having the flexibility is, yeah, you can work your patients around your other things. So I think that's really important. And one point I want to make, again, I'm at 200 patients. I don't think I've ever had more than about 250 in my panel. And it's because I've been able to do that because I've had the other things. Quite frankly, if I didn't have those other things, I'd have to have a bigger panel to earn an adequate income. I'm thinking probably closer to 400, maybe 500. So I never felt the urge to push it. But, if someone had to rely on this solely, they'd have to do a better job than I did of actually going out and recruiting more patients.
Stay with us. We'll be right back. Have you tried an AI scribe in your clinic? Well, I've tried so many, and I can say Heidi Health is the best AI scribe I have come across thus far. With Heidi Health, I can create unlimited customizable templates for my notes to help me truly cut down on the time I'm spending charting. Template for pediatric well child check? Done. Template for weight loss management? Done. Some of my favorite things I've built into my AI template, beyond the general soap note, are having a list of actionables for our team to take after a patient visit, having the diagnoses listed, and creating an after-visit summary for our patients. Not only have I found Heidi Health to be the most helpful, customizable AI scribe so far, it's also more affordable than most out there. So try Heidi Health today and see how you can harness the power of an AI scribe for your practice. To get an entire month of Heidi Pro free, go to the homepage of mydpcstory.com and click on the Heidi Health ad. And so when you were mentioning how you've changed in terms of going from that 150% to 100% working, and you mentioned how you had healthcare through UC San Diego, do you still have healthcare through UC San Diego, or have you had to purchase a different type of plan for you and your family?
So when you retire from the University of California and you've built up a pension, you have a choice when you leave: lump sum payment or a monthly annuity. Two advantages of the monthly annuity, besides the fact that if you're going to have any sort of good longevity at all, you'll actually outlive your lump sum payment. But the other parts of it are, if you take the annuity, you get to continue UC healthcare coverage. Thank you to the taxpayers of the state of California, of which I am one, but everyone else is helping me out. So that's a beautiful thing. And my wife is 2 years older than me. So she transitioned into Medicare last year. I don't have to choose a Medicare plan. UC chooses it for me. It's just seamless. And so it couldn't be easier than that. The other thing is the annuity, the monthly pension plan. I can not only have my wife collect after I'm gone, assuming I go first, but we were able to pick someone beyond her. You can pick a third person. And so it sacrifices a little bit of the monthly now, but this is going to someone who's going to need it in the future and after we're gone. And I couldn't be happier about being able to do that.
That's definitely an incredible opportunity. And I don't know how other universities do it, but especially for those people who are in California who possibly have a UC involvement in the future, it's definitely good information to know.
Yeah. And actually, another piece of advice, which I don't know if I got it early on. If I got it, I didn't follow it. But for folks listening, especially early in practice, and you don't get a pension unless you work for someone else, right? And so I had the good fortune of getting that. But you do have the opportunity of putting away into whether it's an IRA or a 401. If you're incorporated, I don't know if you need to be incorporated to create a practice or a 401k or whatever. Do that early and often. Max it out right away. And you're going to be really happy when it comes time to retire, or perhaps be able to retire early. I had to spend a lot of time catching up later. Just the sooner you can do it, the better. Just live off less, put it away, watch it grow, and have it there waiting for you at the end of the rainbow.
I love that. And I mean, even for those people who are medical students and residents, look into maxing out a Roth IRA. If you have kids, look into those 529s now. It's definitely, that's such sage advice to think about the future and the future generations, even if you're planning that future generation. So thank you so much for mentioning that. And
I just thought of something with Red Hot Chili Peppers. What's their lyric? Give it away, give it away, give it away. It should be put it away, put it away, put it away now.
I love that.
That's the mantra.
I love that. And as we talk about longevity, your impact, I want to ask about the future of your practice. So have you thought about, are you going to recruit somebody to join you as you plan retirement, or do you see you practicing until you're done? How do you envision your practice going into the future?
That's a good question. It's not that many years off. It's probably about a 5 to 7 year horizon, just based on a number of things. Ideally, I'd have someone just sort of come in and take over, maybe co-practice for a while. I'm not sure. That we'd have to adjust the space a little bit because someone would have to have his or her own room to operate, I think. But no, ideally, there'd be a little bit of overlap and then just take it away from there. Gosh, how do you value practices these days? I know there's folks out there who do that. How attractive is it to come in and say, well, all right, I'm going to give you this much money for your book of business or whatever it's called, and here you go. Or do it over time. I don't think you could ask for a lump sum. It would have to be something over time. I'm not sure I want to do that. I'm not sure. I just don't know.
And that's okay.
Now you're making me think about stuff.
But I love planting those seeds because I think about how Dr. Thomas White shared he was thinking about these things when he brought Dr. Buchanan and Dr. Carpenter into his practice in preparation for his patients to have continuity of care while he was still there and able to help mold the practice still and their way of managing the practice itself. So I think that's great.
Yeah, I would like to have someone take it. I do not want at the end for it to be, bye-bye, you're on your own. Go find someone and let me know where to send records. I'd like to have someone come and take over. And that's going to require me to find someone for them instead of them having to go out and find their own. But that's how I'd like it to end at that point.
And when we talk about that goal and we look at the landscape of fewer people choosing primary care, how do you envision making an impact on the future generations of medical students to encourage people to choose primary care, especially when you can practice like a DPC physician?
Yeah, no, that's a really interesting dilemma because there's one side that says, well, just pay us enough and we'll be happy to go into primary care because, we don't get paid enough. $300,000 a year for a salary job. Okay, I'll do that. But it's not there yet compared to the others. On the other hand, who wouldn't want to do a practice like ours where you're taking care of fewer patients and you have a life and you have an adequate income? I don't think any of us are doing it for the money in terms of, this is the best way for me to make the most money. We want to be comfortable. The problem is, if we said, all right, everybody's going to just have a panel of 400 to 600 patients. Well, take your primary care shortage and multiply it by a factor of how many, because now you need to take care of, let's say, 2,400 patients instead of one doc, you need 4. How's that going to work? I go off on the insurance aspect of things. Why is insurance money used to pay for primary care? How does that work? It's money into the system. The insurance company takes now at least it's capped at 15% from the ACA, and then money out to us. What's the added value of that? Why is insurance being used for routine stuff? So in other words, it's prepaid healthcare. It's not insurance. What's the example? You don't use your auto insurance to pay for tires, for a new battery, for an oil change, routine maintenance, and your home insurance is there in case your house burns down or something drastic happens. It's not to maintain it, right? So why should that be used for primary care? Because everybody needs it. Why should it pay for something that everyone needs? Insurance should be for something catastrophic. It should be really bankruptcy insurance, is what I like to say. So take all that money and from the insurance system, pay us a fair amount to take care of a reasonable number of patients. Guess what happens to insurance premiums? They go way down, right? Because it's only for the catastrophic stuff. And of course, there has to be a safety net for those who can't even afford $1 to do something primary care wise. But and what else happens when you do that? When it's all cash pay, it's called competition. And it's competition between physicians. If it's competition at the labs and imaging centers and everywhere else, guess who's going to have to publish all their prices so that things are obvious? Us doctors, sure, but everybody else too. And maybe even competition for pharmaceuticals. What a novel idea.
And so many listeners, I'm sure, are just nodding their heads in agreement with what you've shared. So now I want to ask in closing, are there any other words of advice that you would give to people, no matter where they are in their DPC journey?
Talk to others who are doing it. You know, the Facebook pages of there's different DPC ones. We have our own for California, woohoo. Everybody's got so much to offer. And so take advantage of that. I'm going to give an analogy. So I started my practice October of 2005. And in January, I saw in the Weekly Coast News a flyer for Encinitas Business Exchange. It's a networking group. Maybe I can grow my practice that way. And so I went to the next meeting, and I've been a member ever since. I've worked my way up. I was president for 1 year. I could count the number of people who have become patients in my practice because of that membership. I don't even need all of two hands, okay? But guess what? People have the plumbers for our house and the electric and all that. So I've met great people to do stuff for that. But one of the other members pointed out, and it became really obvious when he said it. He said, I have learned so much from each and every one of you. And it really is. We're not business people by nature. And to be part of a networking group where you really do, I do, learn something every week from everybody else. And so get knowledge from not necessarily the places you'd think you'd get it, and be open to things.
Love that. Thank you so much, Dr. Schulman, for joining us today.
It has been my pleasure.
Next week, look forward to hearing from Dr. Gitu Goyal of First Primary Care in Houston, Texas. If you've enjoyed the podcast and you haven't yet done so, subscribe today and share the episode with a physician you may know who needs to hear about DPC. Leave a 5-star review on Apple Podcasts and on Spotify now as well, as it helps others to find all these DPC stories. Lastly, be sure to follow us on social media. If you're wanting to continue learning more about DPC in the meantime, check out dpcnews.com. Until next week, this is Marielle Concepcion.